Hello, and welcome to the CMEO Snack, Seeing Osteoarthritis Management Through a New Mechanistic Lens. This educational activity is supported by an unrestricted educational grant from Pfizer Incorporated. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine, attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York, New York. Today's activity is eligible for ABIM maintenance of certification credit and as CME for MIPS improvement activities. Complete your post-test and evaluation at the conclusion of the activity, and be sure to fill in your ABIM ID number and date of birth on the evaluation so your credit can be submitted to the ABIM. Over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation, and complete the follow-up survey from CME Outfitters in approximately 3 months. At that time, CME Outfitters will send you confirmation of your participation to submit to CMS, attesting to your completion of a CME activity for MIPS improvement. Our learning objective for this snack is to evaluate emerging treatments to address unmet needs of current osteoarthritis therapies. Despite a variety of therapies available to the practitioner, unmet treatment needs remain. Inadequate pain relief with current treatments is the most troubling aspect of osteoarthritis and responsible for the majority of healthcare visits. In addition, concerns about the risks of long and short-term nonsteroidals and opiates contribute to the unmet treatment needs. And despite these unmet needs, virtually no new agents have been approved for osteoarthritis over the past 2 decades. In the last several years, we have seen a novel mechanism explored for the possibility of relieving pain and dysfunction in patients with osteoarthritis, and that is inhibition of nerve growth factor. Nerve growth factor is a neurotrophin involved in pain signaling and nociceptor gene expression. It contributes to pain hypersensitivity, which is often seen during inflammation and chronic pain, and interestingly, expressed in subchondral bone of patients with osteoarthritis. Inhibition of nerve growth factor binding to its receptors blocks pain-related behaviors and is being studied in osteoarthritis of the knee and hip. There are 2 anti-nerve growth factor monoclonal antibodies in phase 3 development for osteoarthritis, Tenacimab and Vicinumab. Neither of these agents are as yet approved by the FDA for the treatment of osteoarthritis. In order to understand what some of the interest in them may be, let me take a moment and just review some of the patient-reported outcome measures used in clinical trials, because these are used in order to gauge the effectiveness of these agents. The 3 major outcome measures are the KOOS, the knee injury and OA outcome score, the KOOS PS, which is a shorter form of the KOOS, looking at difficulty related to physical activity of patients related to their knee disease, and the WOMAC, the Western Ontario and McMaster University's Osteoarthritis Index, which has both pain and function subscales. These 3 measure different domains of function and are assessed on a 5-point Likert scale, ranging from none, mild, moderate, severe, to extreme. Perhaps the agent that is most closest to clinical approval by the FDA is Tenacimab. There have been several studies looking at the effect of Tenacimab on the hip or knee osteoarthritis. By way of background, adults with hip or knee osteoarthritis with an inadequate response to osteoarthritis analgesics and no radiographic or pre-specified joint safety conditions have been evaluated in close to 89 sites in the United States, Canada, and Puerto Rico. Patients were randomized to one of three groups: Tenacimab at a fixed dose, Tenacimab at a titration or placebo, and co-primary outcomes with a change to baseline to week 16 in the WOMAC pain and physical function subscale scores and the patient global assessment osteoarthritis scores. And there have been several specific reductions reported, both in the Tenacimab fixed dose, the Tenacimab titration dose arms, as compared to placebo. And this was true for both the WOMAC pain score, the WOMAC physical function score, and also in the mean patient global assessment osteoarthritis score. Both Tenacimab treatment groups demonstrated statistically significant improvement for all co-primary endpoints versus placebo at week 16. Here you can see the comparison of Tenacimab versus nonsteroidals and the treatment response. Tenacimab at its two doses are in green, nonsteroidals are in yellow, and you can appreciate that there are differences in terms of the Tenacimab group versus the nonsteroidal group. Here you can see the reduction in WOMAC pain score from baseline in a pooled analysis of the Tenacimab patients. And you can appreciate significant statistical difference in the two Tenacimab groups as compared to the placebo group, whether one is looking at a greater than 30% response, a greater than 50% response, a greater than 70% response, or even a greater than 90% response. Adverse events with Tenacimab at week 16 have also been reported. You can appreciate that the discontinuation rate is about the same with placebo, and the serious adverse event rate is about the same as placebo. The most common treatment adverse events thought to be treatment related were arthralgia, nasopharyngitis, fall, back pain, joint swelling, paresthesias, upper respiratory infection, musculoskeletal pain, and headache, but none of these in the Tenacimab group significantly different from that seen in the placebo group. However, when one looked at an integrated analysis of joint safety with Tenacimab, there was a potential risk of rapidly progressive osteoarthritis. And so recent phase 3 studies have included a comprehensive prospective assessment of joint safety. It is worth keeping in mind as background that the development program of both of these agents was halted for a period of time by the FDA until the relationship of therapy to rapidly progressive osteoarthritis could be reviewed in greater detail. And only then were the manufacturers allowed to continue their development program. So getting back to our integrated analysis, the joint safety outcomes were adjudicated by a blind external adjudication committee. And the adjudicated composite joint safety endpoints included primary osteonecrosis, rapidly progressive osteoarthritis, type 1 or type 2, subchondral insufficiency fracture, and pathological fracture. Among 451 patients, 145 were adjudicated to have a primary outcome, which was a composite joint safety endpoint result. Rapidly progressive OA type 1 in 69%, rapidly progressive OA type 2 in 17%, subchondral insufficiency fracture in 12%, and primary osteonecrosis in 2%. The proportion of patients with adjudicated composite joint safety endpoint results was higher in the Tenacimab treated patients compared to placebo or nonsteroidals, with the incidence increasing with an increasing dose of Tenacimab. And rapidly progressive OA type 2 was more often associated with joint replacement than rapidly progressive OA type 1. Here is a slide looking at the effect of Vicinumab on osteoarthritis pain. The change from baseline to week 16 in the WOMAC pain subscale scores, looking at the measure, the median change, and the p-value versus placebo. One can see that the p-value versus placebo appears to be significant at all of the doses studied and almost in a dose-dependent manner. This slide shows adverse events with Vicinumab at 16 weeks as compared to placebo versus the pooled population of patients who received any Vicinumab dose. There is an increase in infections and infestations versus placebo, an increase in nervous system disorders versus placebo, as well as an increase in gastrointestinal reports as compared to placebo. Arthropathies are also significantly increased as compared to placebo as well. It is hoped that these agents that represent a new class with a novel mechanism will be able to provide relief to a significant number of patients not currently obtaining relief with the agents available. So let's review our SMART goals. In this activity, we've looked at the role of novel targets for pain management studies, such as nerve growth factor, as a result of the unmet need for management of patients with osteoarthritis. And we've looked at the efficacy and safety of novel mechanisms of action for pain management in patients with osteoarthritis. Please go to the link listed in order to see the additional snacks that are available for your review in this topic area. The Rheumatology Education Hub has a number of free resources and education to educate healthcare providers and patients on osteoarthritis, as well as a wide array of other inflammatory disorders. To collect credit for this activity, please click on the link and complete the post-test and evaluation online. Be sure to include your ABIM identification number and date of birth on the evaluation so that it can be submitted to the ABIM for your maintenance of certification credits. You'll be able to print your certificate or statement of credit immediately after completion. Thank you for participation in this activity. I hope it's been useful.